Today, we're going to take an in-depth look at local anesthetics and how it relates to regenerative medicine. We're going to start at the very beginning with a plant called Erythrooxylum coca. The discovery of local anesthetics originated from Erythrooxylum coca, known as the coca plant. The coca plant is where the alkaloid of cocaine, erythrooxylin, is derived from. The coca plant is indigenous to South America in Peru, Bolivia, and Colombia. Coca leaves are part of culture and is used as tea, food, and medicine. If you ever go to Peru, you'll easily find coca leaves to chew on or to drink as tea. It is natively used to help with altitude sickness, gastrointestinal complaints, pain, and fatigue. A large amount of coca leaves are needed into cocaine. About 200 to 800 kilograms of coca leaves are needed to make 1 kilogram of cocaine paste. And the cocaine content of unprocessed coca leaves is about 0.13% to 0.68% of erythrooxylin. The chemical purification of the coca plant into cocaine increases its toxicity and addictive properties. As many of you already know, cocaine is related to many overdoses and cartel-related deaths. By 1855, the German chemist Friedrich Gadig had separated erythrooxylin compound, also known as cocaine, from coca leaves. In 1859, Albert Niemann isolated purified cocaine. In 1865, Albert Niemann's student, Wilhelm Lawson, determined cocaine's molecular formula, as you can see here, 17 carbon, 21 hydrogen, 1 nitrogen, and 4 oxygen. Basil von Enriep, in 1880, published the results of his studies concerning the application of cocaine to humans. In the conclusion of his work, he recommended cocaine as a surgical anesthesia. In 1884, Carl Kohler used topical cocaine for the first surgery, which was a cataract surgery. So cocaine now obviously is illegal to use as a local anesthetic. However, it led to the discovery of other local anesthetics. In 1905, the first pharmaceutically derived local anesthetic from cocaine was created, an ester local anesthetic called Procaine. This anesthetic was not the ideal local anesthetic because of its very long onset, short duration of action, low potency, and allergic potential. Since the discovery of cocaine, many variations of local anesthetics were created. In the 1940s, the first amide local anesthetic was synthesized, lidocaine. Since the 1940s, many variations of amide local anesthetics have been created, based on their onset, toxicity, potency, and duration of action. In 1957, the second amide local anesthetic was synthesized, bupivacaine, also called Marcaine. There are two major classifications of local anesthetics, amides and esters. The amide local anesthetics are listed here: lidocaine, mepivacaine, bupivacaine, levobupivacaine, prilocaine, ropivacaine, and atidocane. The ester local anesthetics are procaine, 2-chloroprocaine, tetracaine, cocaine, and benzocaine. Local anesthetics are classified as either an amide or an ester local anesthetic based on their chemical structure. This determines its chemical stability, metabolism, and allergic potential. Amides tend to be more stable, and esters are more unstable. There are three major components to their structures. On the left here, you see the aromatic portion, then the intermediate chain, and then the amino group on the side. So each component of these that I just talked about of the local anesthetic contributes a distinct property to the local anesthetic. The constituent of the intermediary chain determines whether the local anesthetic is classified as an aminoamide or an amino ester type local anesthetic. The aromatic portion of local anesthetics determines its lipid solubility, which allows anesthetics to cross nerve sheaths and cell membranes. The amine group is the hydrophilic portion or the water-soluble portion. This acts as an on and off switch for lipid and water solubility, which depends on the number of bonds attached to it. It exists as a tertiary amine with 3 bonds and is lipid soluble, or it can also exist as a quaternary amine with 4 bonds and be water soluble. The main types of amide local anesthetics used in regenerative medicine are ropivacaine, brand name Neuropen, brand name xylocaine, and bupivacaine, brand name Marcaine. This graph represents their pharmacokinetics that can be used to determine what the best anesthetic is. It is important to be safe when using local anesthetics, but calculating the max dose for each patient can be repetitive, so I calculated the max dose for a 100-pound patient for each of the local anesthetics, as you can see here at the bottom. Since most adults will be over 100 pounds, this can give you a ballpark understanding of what a safe dose of local anesthetic would be. So looking at ropivacaine, the max dose is 3 milligrams per kilogram, or the total max dose of 300 milligrams or 60 cc's. And the calculation, I've even written it out here for you, for a 100-pound patient is 20 cc's or 27 cc's or 27 milliliters. And then the max dose for lidocaine would be 4 milligrams per kilogram with a total max dose of 300 milligrams or 30 cc's, with the max dose for a 100-pound patient being 18 cc's. For bupivacaine, it's 2 milligrams per kilogram with a total max dose of 175 milligrams or 70 cc's, with a 100-pound patient being 36 cc's. For levobupivacaine, the max dose is also 2 milligrams per kilogram with the total max dose of 175 milligrams or 35 cc's. The max dose for a 100-pound patient would be 18 cc's per milliliter. And you can tell that the difference between this is if you look at the potency of this bupivacaine is 0.25% versus levobupivacaine is 0.5%. And so that's where the differences are coming from there. The one with the shortest onset time, as you can see, was lidocaine, and then is bupivacaine, levobupivacaine, and then finally ropivacaine. The one with the longest duration is levobupivacaine, next ropivacaine, then bupivacaine, and finally lidocaine. For ester local anesthetics, procaine is the most commonly used, but I also wanted to give it a comparison, so I also put another local anesthetic that we're going to be talking about in this lecture, chloroprocaine, but it's not commonly used in regenerative medicine. The max dose for procaine is 7 milligrams per kilogram with a total max dose of 500 milligrams or 50 cc's, and the max dose for a 100-pound patient is 32 cc's. For chloroprocaine, it was 11 milligrams per kilogram, total being 800 milligrams or 80 cc's, with the max dose for a 100-pound patient being 50 cc's. So to compare with the mild local anesthetics, procaine has a longer onset time than lidocaine, but a shorter onset time than ropivacaine. Its duration is longer than lidocaine, but shorter than ropivacaine and bupivacaine. So overall, we can see that you would generally have to inject a lot of local anesthetic in the periphery to reach the max dose. And usually we're not going anywhere near these max doses when we are doing regenerative medicine injections. So now let's review some foundational organic chemistry to make sense of the differences between certain local anesthetics. Isomers are molecules that have the same molecular formula. For instance, the molecular formula of lidocaine has 14 carbon, 22 hydrogen, 2 nitrogen, and 1 oxygen. The term isomer can be further broken down into structural isomer, also known as a constitutional isomer, and stereoisomers. Structural isomers have the same molecular formula with different connectivity. They don't usually have chiral centers. And for example, I have in a picture here the graphic of butane and isobutane, which they have the same molecular formula but are arranged differently. So that would be structural isomers. Stereoisomers have the same molecular formula, are arranged differently in 3 dimensions, and have chiral centers. So molecules with chiral centers exhibit stereoisomerism. A chiral center is usually a carbon atom, could also be sulfur, phosphorus, or nitrogen, with 4 different substituents attached to it. There are 2 types of stereoisomers, optical and geometric stereoisomers. Optical isomers are also known as enantiomers. 2 examples of enantiomers are levorotary, which can be labeled as L, S, or negative, which rotate light counterclockwise or to the left, and dextrorotary, which is labeled as R, D, or positive, which rotates like clockwise or to the right. Geometric isomers have the same connectivity but differ in three-dimensional arrangements around a double bond. So we're going to be talking about optical isomers as it relates to local anesthetics. So for drugs, chirality significantly affects the drug's biological activity. With relationship with local anesthetics, isolation of a stereoisomer in a racemic mixture can improve its toxicity. The best example is with the MI-type local anesthetics, bupivacaine and levobupivacaine. Bupivacaine is a racemic mixture of both L and R stereoisomers. Levobupivacaine isolates the L isomer. Research shows levobupivacaine has less toxicity than bupivacaine with similar pharmacokinetics. Levobupivacaine has less cardiac and central nervous system toxicity. It is proposed that this happens because the racemic or R isomer have a great affinity to sodium channels in cardiac myocytes and cause more of a dramatic decrease in the rate of depolarization in cardiac myocytes. Newer local anesthetics like ropivacaine isolate the L enantiomer and have less toxic symptoms. The next term, pharmacodynamics, refers to the effect of drugs and their mechanism of action. This next section is a quick review of some neuroanatomy and physiology and then how it relates to local anesthetics. So nerves are organized into two major types based on anatomy, myelinated and unmyelinated. Myelin increases the speed of the signal from the periphery to the brain. These are the following classifications of nerves based on their degree of myelination from greatest to least, shown here. So the three that are relevant to pain are alpha gamma, alpha delta, as well as the C nerve fibers. Resting membrane potential is the electrochemical difference of charges across the membrane at rest. Positively charged cations line the outside of the neuronal membrane and negatively charged anions line the inside of the neuronal membrane. The membrane is impermeable to sodium cations and permeable to potassium cations. This electrochemical gradient is maintained by ATP sodium-potassium pumps. This pump exports 3 sodium out for 2 potassium into the neuron. The resting membrane potential of a neuron is more negative on the inside at negative 70 millivolts. When a stimulus is felt and reaches a certain threshold, an action potential is felt and the resting membrane potential moves to be more positive, causing a depolarization. This action potential is allowed to happen because voltage-gated sodium channels are allowed to open and sodium rushes into the neuron along its concentration gradient. The membrane resting potential is restored after sodium channels close and potassium channels open, repolarizing the neuron. The voltage-gated sodium channels we just mentioned, which you can see an example for in this picture, the local anesthetics bind on the inside at the alpha subunit, inactivating the channel. And by inactivating the voltage-gated sodium channels, it stops action potentials from propagating along the nerve. Without action potentials, no information or pain signals can be sent back to the brain. Different aspects of local anesthetic structures influence their function in the body. In the next few slides, we're going to talk about these differences. The pH of local anesthetics affect its onset time. Before we go into that a little bit more, we're going to do a quick review of some pH chemistry. The Henderson-Hasselbalch equation, which you can see here, is used to estimate the pH of a solution. pKa is based on the acid dissociation constant, which determines its ability to donate a proton. In a solution, the pH equals the pKa when 50% of the acid is dissociated into its conjugate base. A hydrogen atom, also called a proton, when discussing acid-base. The ionized form has a charge and thus is hydrophilic. The non-ionized form has a neutral charge and thus is lipophilic. And we're going to go into a little bit more here about why that is important. So, local anesthetics must be lipid soluble to penetrate the neuron to reach the active site at the voltage-gated sodium channel inside the neuron. Thus, it must be in its neutral form to cross the neuronal membrane. In a syringe, local anesthetics exist in a stable solution as a water-soluble quaternary salt, which is protonated, ionized, and hydrophilic. When the pKa is greater than the pH, it will also exist predominantly in its ionized quaternary salt form. The closer the local anesthetic is to the pKa, to the physiological pH of 7.4, the more local anesthetic will be dissociated into its non-ionized. Inflamed tissues will also affect the ability of local anesthetics to work. It tends to cause tissues to be acidic, which would cause local anesthetics with a higher pH to be less effective. A trick you can do to favor the lipophilic form is to increase the pH by adding sodium bicarbonate. This will increase the speed of onset by increasing penetration into the neuron. The more lipid-soluble the anesthetic is, the greater the ability to cross the neuron's lipid-soluble membrane, thus providing it with the shorter time to onset. If you look at this graph here to the right, you see that the quaternary salt is dissociated into the deprotonated tertiary salt. The deprotonated form crosses the epineurium and the neuronal membrane to reach inside the cell to act on the voltage-gated sodium channels. Once inside the cell, the local anesthetic must gain a hydrogen atom to form its quaternary structure. The protonated quaternary salt is what acts on the active site of the voltage-gated sodium channels. The potency of a local anesthetic is the minimum dose of local anesthetic that can be used to cause a complete nerve block. A higher potency local anesthetic allows for lower amounts of local anesthetic to be used. Potency of a local anesthetic is closely related to its lipid solubility and pKa. Lipid solubility of the local anesthetic determines its ability to penetrate lipid-rich nerve sheaths and cell membranes. This is important because, as you remember from before, local anesthetics block voltage-gated sodium channels from the inside of the neuron. Local anesthetics lipid solubility is affected by two things. It's aromatic ring and aliphatic substituents at the designated R groups in the picture shown here. By increasing the length of its carbon backbone, this will increase its lipid solubility. Lipid solubility also affects the rate of absorption. Lipid-soluble agents are absorbed more slowly and stay around longer. Protein binding of local anesthetics also correlates with the duration of the local anesthetic. It happens to be that local anesthetics with higher molecular weight and lipid solubility tend to have higher protein binding. The affinity of local anesthetics to plasma proteins mirrors its affinity for proteins at voltage-gated sodium channels. Thus, local anesthetics with higher protein binding capacity will bind to the active site for longer periods of time. Vascular absorption also affects duration, which we will discuss more here in a little bit. So now we're going to review the pKa and protein binding for the major local anesthetics used. The physiology of local anesthetics is mostly consistent with the clinical data for local anesthetics, with some variations. Ropivacaine has the highest pKa, as you can see here, 8.1, and it has 17 carbons. We would expect it to have a longer time to onset and a longer duration, which is consistent with what we had talked about before. Lidocaine has the lowest pKa out of all of them, and has the quickest time to onset and the shortest duration, which is also consistent. Bupivacaine has the same pKa as ropivacaine, but has a shorter time to onset. This could be because it has an extra carbon on its aliphatic chain, causing it to be more lipophilic, but I'm not really sure. It was just kind of something that I conjectured because that didn't seem to be very consistent. So procaine and chloroprocaine, we would have expected them to have the slowest time to onset out of all of them because the pKa is the farthest away from the physiological pH of 7.4. However, ropivacaine had the slowest time to onset. It also has the least amount of carbons and hardly any protein binding. We would expect the duration to not be very long, which is mostly true. Lidocaine was the only one with similar duration. However, lidocaine had significantly more protein binding. Procaine and chloroprocaine time to onset is similar to bupivacaine, which is interesting because their pKa is higher. Pharmacokinetics is the movement of drugs within the body. We're going to specifically talk about absorption, distribution, and metabolism in this section, and how these factors affect peak plasma concentration and allergic potential of local anesthetics. Absorption is determined of how fast a local anesthetic reaches the blood. Absorption is related to the vascularity of the injection and the vasoactivity of the injection site as well. All local anesthetics cause vasodilation by relaxing vascular smooth muscles, with the exception of cocaine. The rate of absorption is also affected by the location of the injection. The highest absorption rate is intravenous, obviously, and then it goes in decreasing order: intercostal, caudal, epidural, brachial plexus, femoral, sciatic, and subcutaneous. And also, if an area is more vascularized or inflamed, local anesthetics will be cleared more quickly from the area. After the local anesthetic reaches the blood, the rate at which local anesthetics distribute to tissues depend how fast those tissues are perfused. Rapidly perfused organs are, as you can see here, brain, myocardium, liver, lungs, and also kidney and spleen. Slowly perfused organs are adipose and muscle tissue, which is where we inject most regenerative injections. Peak blood concentration of local anesthetics is directly proportional to the dose and indirectly proportional to cardiac output and the time of injection. There should be a graphic here that's not loading that shows that, that relationship. So sorry about that. Peak plasma concentration is usually the venous concentration after injection with local anesthetic. This is used to determine toxicity. We will also talk about studies that measure arterial peak plasma concentration and how it relates to local anesthetic toxicity. This graph looks at the absorption of mepivacaine, lidocaine, prilocaine, and atidocane. We're going to focus on the section that talks about lidocaine. Remember that intercostal injections have the second highest absorption rate, second to injecting directly into the vein. In this study, the peak concentration of lidocaine was checked at 15 minutes after an injection was given over 1 minute. Intercostal injection of 400 milligrams of lidocaine brought plasma concentrations up to about 6.3 micrograms per milliliter. Just as a note, you usually begin to see toxic symptoms when blood concentrations reach about 5 micrograms per milliliter. Remember, the total max dose for 1% lidocaine is 300 milligrams or 30 cc's of 1% lidocaine. According to this, it seems that you would need to inject it around the maximum dose in the periphery to possibly see toxic symptoms. As you can see here, the peak plasma concentration does vary based on the location of the injection and the type of local anesthetic used. The amide or ester chain between the aromatic portion and the amino group in local anesthetic determines its classification and how it will be metabolized. The ester type local anesthetic, like procaine, are metabolized in the blood, and the amide type local anesthetic, like lidocaine and ropivacaine, are metabolized in the liver. Since ester type local anesthetics are broken down in the blood to PABA, or para-aminobenzoic acid, less toxicity from them has previously been noted. The chart here shows the results from a study that showed how fast procaine, 2-fluoroprocaine, and tetracaine were hydrolyzed into its para-aminobenzoic acid infusion. Administration of local anesthetics was terminated after 25 minutes of 1 milligram per kilogram per minute, or when toxicity symptoms of generalized twitching, convulsions, breathing difficulties, loss of consciousness, or severe disorientation occurred. Chloroprocaine was 4 times faster than procaine to hydrolyze into PABA. Chloroprocaine resulted in 7 times higher. 2-fluoroprocaine was tolerated the best out of all of the local anesthetics tested. For 25 minutes after the injection of local anesthetics, 10 out of the 12 tolerated chloroprocaine, 3 out of the 12 tolerated procaine, and 0 out of 12 tolerated lidocaine. So now that we understand generally how toxicity works between amide and ester local anesthetics, let's compare their allergic potential. Ester-type local anesthetics like procaine are more well known to cause an allergic reaction. Amide-type local anesthetics have rarely been implicated in an allergic reaction. What is the difference between an ester local anesthetic and an anesthetic that contains an ester side chain? The difference is how they are metabolized and what their metabolites are. Remember, procaine is an ester-type local anesthetic that has an ester linkage in the intermediate chain that links the aromatic ring and the amino group. Articaine, as you can see here, is an amide local anesthetic which combines an aromatic ring and an amine group via an amide linkage. Articaine has an ester side chain coming off of its aromatic ring. Neither of these esters are what cause local anesthetics to have an allergic reaction. It's the para-aminobenzoic acid byproduct of when local anesthetics are hydrolyzed that causes an allergic reaction. Chloroprocaine, as we remember from a couple slides ago, was better tolerated but created more PABA. This local anesthetic, even though it causes less toxicity, has a higher allergic potential. One of the major types of allergic reactions that occur with local anesthetics is an immediate type 1 hypersensitivity reaction. This reaction occurs when the immune system recognizes large foreign proteins in the body. However, PABA is a small molecular weight molecule that is recognized by the immune system because it is attached to a carrier protein, allowing it to be large enough to be recognized by the immune system. The drug metabolites are often called haptens. Haptens are the small molecules that combine with the carrier protein to be transported into the blood. The hapten and carrier protein complex becoming large enough to be recognized by the immune system to cause an allergic reaction. And you can see that here in the graphic. There are 4 types of allergic reactions to procaine, though, and that is just the one that we are most familiar with. There's also contact dermatitis, atopic reaction, serum sickness pattern, and accelerated serum type. Contact dermatitis results from topical exposure to local anesthetics. This can easily be tested for in a patch test. An atopic reaction is the type 1 hypersensitivity reaction we talked about that can cause bronchial asthma, urticaria, angioneurotic edema, and possible death. The serum sickness pattern is a reaction that can occur 2 to 12 days after the first injection with procaine. That means your patient could have an allergic reaction to the local anesthetic after they leave your office days after the injection. The reaction may include urticaria, fever, joint pain, and lymph node enlargement. This is usually a benign response, though. Accelerated serum type also is what I think is the most scary one out of all of these. The onset is sudden and severe. This results from sensitization by smooth muscle antibodies. This cannot be tested for in a patch test because it's mediated by different antibodies than in atopic. The reaction includes shock, respiratory distress, capillary congestion, visceral congestion, dilation of the right side of the heart, alveolar transudation, and possible death. And what makes this one scary to me is that it's hard to predict how your patient will react to the local anesthetic. And that's because they could have however many injections and still have an allergic reaction. And with the serum sickness pattern, they could have a reaction even days after they had an injection. So now I want to go through a few cases with you guys that show fatal reactions to procaine local anesthetic. This first case is of a 58-year-old male who presented with blood pressure of 160/90 with status asthmaticus. Procaine had been given to this patient before to treat his status asthmaticus without any adverse reaction. He was hospitalized again years later for the same condition, and he was given an unknown dosage of procaine and died as a result of procaine allergy. This would be an example of accelerated serum type reaction to procaine. This highlights the importance of, regardless how a patient has reacted to procaine before, they may still have a reaction. Here's another case from a 45-year-old male who presented to clinic for complications from a right pneumoectomy resulting in a hydropneumothorax and empyema. He has a pertinent past medical history of bronchogenic carcinoma, right-sided pneumoectomy, hydropneumothorax, empyema, lymphadenitis, and gastric adenocarcinoma. He had previously received 3 procaine injections for various procedures with no adverse reactions. On the 4th injection, he had severe dyspnea, choking, orthognopenia, and cyanosis. He died within minutes of the procaine injection. This is another example of accelerated serum type reaction to procaine. Here is an example of a procaine allergy death in a young, seemingly healthy patient that was 29 years old who presented to the clinic for a tooth extraction. She had no other reported medical conditions. She had previously received procaine on one other occasion without an adverse reaction. Her reaction to this injection was cold, clammy, comatose, acute respiratory distress, vomiting, pinkish sputum, dyspnea, orthognopenia, cyanosis, bilateral pulmonary edema, and she died 17 hours later. This is also another example of accelerated serum type reaction to procaine that resulted even after being able to get to the ER in time. IV dosing. This next section, we're going to talk about intravenous injections with local anesthetics. Lidocaine can be used intravenously as a therapeutic agent for pain, arrhythmias, and convulsions. By understanding how we can safely inject directly into the bloodstream, we can minimize toxicity if we accidentally inject local anesthetics intravenously. This is an article published by the Ottawa Hospital in 2016 as their policy for IV lidocaine to treat post-operative pain. They broke it down into 4 steps: preparation, initiation, infusion, and termination. The first step, preparation, is used to make sure the environment in which IV lidocaine is administered is safe and has the proper equipment. IV lidocaine should be given in an area with monitoring of the patient's heart and vitals, including pulse oximetry, along with a properly equipped crash cart. The initiation phase is where the loading dose is provided of IV lidocaine. The initial bolus dose should be around 1.5 milligrams per kilogram, given over a 2 to 4 minute time period, followed by an infusion. The loading dose for about a 100-pound patient would be 68 milligrams or 6.8 cc's of 1% lidocaine. The next phase, the infusion phase, has more of a variable dose. The range for IV lidocaine infusion rate is 0.5 to 2 milligrams per kilogram every hour. However, the usual starting dose is 1 milligram per kilogram every hour. This would be 4.5 cc's per hour for a 100-pound patient. The dose should only be changed every 8 hours to allow for a steady state of serum levels. The rate can be increased or decreased by 0.25 to 0.5 milligrams per kilogram every hour, and that would be based on signs of toxicity and levels of reduction in pain. The final phase is determined when the IV should be terminated. Typical duration of IV infusions of lidocaine is between 12 and 72 hours. Discontinued infusion is determined by bowel recovery after surgery, intolerance to, or adequacy of oral pain medication. Local anesthetics such as lidocaine are also used therapeutically in acute cardiac life support for ventricular fibrillation and ventricular tachycardia. The American Heart Association recommended an initial bolus of 1 to 1.5 milligrams per kilogram of lidocaine as an antiarrhythmic drug in ACLS. A repeat dose of 0.5 to 0.75 milligrams per kilogram every 5 to 10 minutes as needed. The maximum cumulative dose is 3 milligrams per kilogram. For a 100-pound patient, the initial dose would be between 4.5 cc's and 6.8 cc's, which is kind of similar to what we had talked about on the last slide with the 6.8 cc's of 1% lidocaine. The repeat dose would be between 2.25 cc's to 3.4 cc's of 1% lidocaine, and the total max dose would be 13.6 cc's or 136 milligrams of 1% lidocaine. So toxicity. Local anesthetic toxicity is abbreviated and recognized as the last adverse event. As we discussed previously with the local anesthetic pharmacokinetics, they act on voltage-gated sodium channels inside the neuron. However, as the plasma concentration goes up, local anesthetic toxicity has more of a widespread effect, affecting more than just the voltage-gated sodium channels. As you can see here from left to right, it spreads from voltage-gated potassium and calcium channels, and then acetylcholine, NMDA receptors, and it also can cause mitochondrial dysfunction and disrupt oxidative phosphorylation. Paracelsus, the father of toxicology, quoted, "The dose makes the poison." Local anesthetics can be therapeutic or toxic depending on the dose. Earlier in the presentation, we had talked about lidocaine being used intravenously to manage used as an anticonvulsant and antiarrhythmic for ACLS, like we had just mentioned. Toxicity from local anesthetics occurs in the central nervous system and the cardiovascular system. The systemic toxicity first affects the central nervous system and then the cardiovascular system. And you can see that here on the illustration with the cardiovascular system on the left, central nervous system on the right, and the lidocaine blood levels in the center in micrograms per milliliter. And you can see that the colors are shaded with increasing effect. So the white is no effect. The lightest shaded color is therapeutic. The darker shades are increasing levels of toxicity. In general, blood levels of lidocaine less than 5 micrograms per milliliter is not toxic. From 0.5 to 4 micrograms per milliliter are the blood levels of lidocaine related to its anticonvulsant actions. From 1.8 to 5 micrograms per milliliter are blood levels of lidocaine related to its antiarrhythmic action. CNS toxicity happens when cerebral blood levels are greater than 4.5 micrograms per milliliter of lidocaine, and tonic-clonic seizures generally happen at around 7.5 micrograms per milliliter of lidocaine. Cardiovascular toxicity occurs greater than 4.5 micrograms per milliliter, and cardiac arrest generally occurs at levels greater than 10 micrograms per milliliter. So, toxic plasma levels vary based on the anesthetic used. This is just talking about lidocaine blood levels. And as we had saw previously with injecting in the periphery, there are different amounts of local anesthetics depending on where it's injected or what it is that are related to toxicity reactions. However, in general, it did seem that lidocaine, prilocaine, and mepivacaine specifically had toxicity levels above 5 micrograms per milliliter as well. So now let's talk more specifically about the stages of LAST. Cardiovascular system is more resistant to local anesthetic toxicity than the central nervous system. The pattern of toxicity goes from CNS excitation, CNS depression, to cardiovascular excitation to cardiovascular depression. However, like we were saying before, this is typical presentation and patient may have an atypical presentation. For instance, if the patient has CNS toxicity and cardiovascular toxicity signs that happen at the same time, that could be a scenario. If it is injected directly into vascular access to the brain, symptoms may appear more rapidly within seconds to convulsions, coma, respiratory depression, and cardiovascular toxicity. CNS excitation phase corresponds with peak plasma concentrations between 5 and 10 micrograms per milliliter, which includes the initial stage, which you can see here as numbness, metallic flavor, altered taste, and lightheadedness. The next phase is the preconvulsive phase between 4.5 micrograms per milliliter to 7 micrograms per milliliter, which includes the symptoms of tinnitus, visual disturbance and nystagmus, slurring of speech, muscle twitching and tremors, irrational conversations, and unconsciousness. And the last phase of CNS excitation is the convulsive stage, 7.5 micrograms per milliliter to 10 micrograms per milliliter, and that's where grand mal convulsions or general tonic-clonic seizures happen. Following that, when you're going 10 micrograms per milliliter or above is where CNS depression happens, and that's where you'll see coma, apnea, and respiratory depression. The cardiovascular excitation also starts between 5 micrograms per milliliter to 10 micrograms per milliliter, but they're a little less severe. There's hypertension, tachycardia, and ventricular arrhythmia. It's when you get above the 10 microgram per milliliter is when you start having the more severe cardiovascular depression symptoms, which would be low cardiac output, decreased contractility, ECG widening, arrhythmias, bradycardia, AV dissociation, ischemia, hypotension, cardiac arrest, and asystole. So the point of this is it's really important to know what the initial signs of CNS and cardiovascular excitation are, and so that way you can catch it early on and prevent these more serious things from happening. So this slide shows the most common side effects related to ropivacaine, as you can see in black, bupivacaine in that gray color, and then white is the placebo. And they were visual disturbances, hearing disturbances, tingling, and dysarthria. This study here compares intraarterial versus intravenous toxicity. I wish this had loaded here. I'm sorry about that. Other toxicities that we looked at with intravenous are going to be with intravenous to determine peak plasma concentration, but you could also intraarterially, and that's why I wanted to explore this as well. And would there be a higher or lower possibility of toxicity if you were to inject it intraarterial versus intravenously? And so this study looked at the differences between ropivacaine and bupivacaine. This study infused 2 mLs per minute, which corresponded to about 10 milligrams per minute. The infusion was stopped when definite signs of toxicity like dysarthria, shivering, muscular twitching, and muscular rigidity were exhibited, or the max dose of 250 milligrams was given. If this table was showing here, you would be able to see that the arterial concentration associated with toxicity is higher. You have a higher concentration in the arterial than the venous concentration, meaning that you could have more local anesthetic injected intraarterially than intravenously and not cause toxicity reactions. So what would have been shown here is the total arterial max plasma concentration of ropivacaine was 4.3 micrograms per milliliter, and the total venous max plasma concentration of ropivacaine was 2.2 micrograms per milliliter. The maximum tolerated dose for ropivacaine was higher than that of bupivacaine for both intraarterial and intravenous. The total max plasma concentration of ropivacaine was 2.2 micrograms per milliliter versus bupivacaine was 2.1 micrograms per milliliter. The total arterial max plasma concentration of ropivacaine was 4.3 micrograms per milliliter, whereas bupivacaine was 4.0 micrograms per milliliter. So the maximum tolerated peak concentration decreases with the higher infusion rate and cardiac output. And you can see that injecting intraarterially is actually, I guess, safer than injecting intravenously, depending on where you are injecting. So the unbound form of local anesthetic is the active form, and much lower max plasma concentrations are associated with toxicity. This study reveals venous max plasma concentration of unbound was 0.15 micrograms per milliliter, and the arterial max plasma concentration was 0.56 micrograms per milliliter. And once again, sorry that you can't see that comparison here, but I can send these slides out later where you can actually look at those for yourself. Unbound ropivacaine had a higher peak plasma concentration in arterial circulation. Amide local anesthetics are bound to plasma proteins like alpha-1 acid glycoprotein, abbreviated AAG, and albumin to a minor extent. The amount of AAG available depends on age and stress, like surgeries, and so infants have less AAG than adults do. The ability of local anesthetics to bind protein and the person's protein status may affect their ability to tolerate local anesthetics intravenously or intraarterially. One study observed aortofemoral intraarterial lidocaine. 400 to 680 milligrams of lidocaine was given over 60 to 75 minutes. The initial bolus amount was 200 milligrams. This is a relatively long time to administer local anesthetic. They found that their peak max plasma concentration was between 2.4 and 4.6 micrograms per milliliter. And remembering above 5 micrograms per milliliter when you start seeing toxicity reactions. In other studies, large amounts of lidocaine was administered intravenously in more of a reasonable amount of time, and they injected 880 to 1,040 milligrams of lidocaine over 11.5 to 13 minutes, and peak plasma concentrations were between 4.8 and 5.8 micrograms per milliliter. So according to these studies, it is hard to determine which of these had an increase in toxicity because peak plasma concentrations are related to the rate of infusion. However, we do see the relatively large amounts of local anesthetics can be injected intraarterially and intravenously with minimal side effects. 40 to 68 cc's of 1% lidocaine intraarterially and 88 to 105 cc's of 1% lidocaine over the designated time periods. Remember, these injections were made in the periphery, and that the proximity to the brain or the heart may affect the amount of local anesthetic that can be used before toxicity occurs. So now let's talk about the scarier toxicity reactions that can occur with local anesthetics. So what happens if you inject local anesthetic into cerebral circulation? It causes toxicity reactions to occur at much lower amounts than would be tolerated in the periphery. And why is that? And one of the reasons that have been suggested is that you're delivering undiluted amounts of local anesthetics directly into the cerebral circulation towards the brain instead of back towards the heart. And so this is where you can see from this picture, it's caused by something called reverse flow. You're pushing enough pressure into that syringe that it's going against the natural flow and directing directly into the brain instead of going